Griffith, the Vice Chairman of the Subcommittee, for 5 minutes.
Thank you very much, Mr. Chairman. I greatly appreciate it. Dr. Goodrich, my colleagues, Congresswoman Black, Congressman Adrian Smith, Lujan, and Crowley, and I recently introduced the Reducing Unnecessary Senior Hospitalization Act of 2018, which seeks to improve quality in nursing homes by providing quality acute care at patients' bedsides via telehealth instead of transferring them to the hospital. By CMS's own calculations, 2/3 of hospital transfers are avoidable, leading to increased costs to Medicare and negatively impacting health outcomes and quality of care. What are your thoughts on the potential for complementing current nursing home staff with emergency-trained first responders utilizing telehealth to connect physician specialists, i.e. emergency physicians, that might not otherwise be available to this patient population?
So thank you for that question and letting me know about this pending legislation. So we do understand that, as you mentioned, transfers to the hospital. That's a very disruptive event for a nursing home patient, and many of them are avoidable. This is something we actually measure as part of our quality reporting program. So we're certainly aware that there's a significant level of admissions to a hospital. So we would be very interested and willing to provide technical assistance to you and your staff on this legislation at your convenience.
Well, I appreciate that very much, and thank you. I'm really excited about telemedicine. Representing a fairly rural district, I can tell you that one of my small nursing home chains has implemented wound care by using telemedicine. So they have a wound care specialist who's available, and one of their nurses will go in to see the patient who may have a bed sore or some other kind of injury, and they're looking at it through a pair of glasses that has a camera on it, and the wound specialist, wherever they are in the United States, can see that wound, get a color picture, be able to then to tell the nursing home staff what needs to be done to make sure that that wound is being treated properly and taken care of. So I'm really excited about telemedicine as a whole. Let me go to your new payroll-based journal for staffing, because I do think that sometimes there may be some confusion, and while we recognize that we want the staffing to be there so you all can use it as a tool, you mentioned it in your statement. Mr. Dickin mentioned in his that there was, the self-reporting hadn't worked because there was a difference. But I think that may be a little unfair to CMS and to the nursing homes affected, to some of them, not the bad actors, but people that are really trying. Because am I not correct that it's a slightly different standard? Under self-reporting, if you had a salaried employee who worked 50, 55 hours a week, they got to count that extra time. But under your report, which I have no quarrel with, I'm just saying they're different, you only count those folks at a maximum of 40 hours of being on the floor. Likewise, if you have an LPN who's doing supervisory work, they don't get credit for their supervisory time where an RN would. Again, no quarrel with the change, but just saying that to say that the old reporting system was intentionally under-reporting might not be fair, since it's really apples to oranges. Wouldn't you agree with that?
The previous reporting system was essentially a 2-week snapshot that the nursing homes completed on a form during their recertification survey. Mm-hmm. The current system, as you mentioned, is based upon daily staffing levels of numerous different types of staff that the nursing homes have to report quarterly to CMS. Certainly as we were standing that up, we had to make certain decisions around ensuring that what is reported is auditable back to the payroll, so that it could be, as is required by law, so that it could be as accurate as possible. So the situations you mentioned around a salaried employee, yes, we only count the 40 hours a week that they would be working.
And I don't have any quarrel with that, but
Sure.
to say that there was understaffing previously when you're using different metrics, it wouldn't really be fair to CMS or to some of the nursing homes. Wouldn't that be fair to say?
I would say it's very difficult to compare the two.
Difficult to compare, okay. The Commonwealth of Virginia, partnering with healthcare providers, developed a long-term care mutual aid plan, which is a voluntary agreement among participating nursing homes that they will share supplies, resources, and house residents from other facilities if a serious need arises. We heard Chairman Walden say earlier that one of his nursing homes or small chain had a facility in California, was looking to move patients to Oregon. This is actually a statewide system. Are you familiar with this type of plan, and do you think it'll work, and do you think other states will adopt it?
I am not familiar with this kind of plan, but we certainly would be interested to learn more. And again, our staff would be glad to follow up with you on this.
Very good. Thank you so much. I yield back, Mr. Chairman.
Gentleman yields back. Chair will now recognize the gentleman